Okay, there's some other physical and mental function um, considerations or challenges in people who have Down syndrome. Um, they tend to have a mild to moderate intellectual disability. Oftentimes, um, that falls within these two ranges. There are not a lot that have profound or severe intellectual impairments, although there are some. But in general, people with Down syndrome are able to learn, they're able to live, work, and play within the community. They tend to have expressive and receptive language deficits. Receptive is stronger, so they're able to understand more than they're able to express. They do have some intelligibility issues impacting their ability to communicate, so it can be difficult to understand them sometimes. They have poor verbal short term memory, so saying something to them, they're going to have a hard time remembering it. So, using things like visual cues or some sort of visual is helpful. They have difficulty with auditory attention, so paying attention when someone is speaking for a long period of time. They can have some behavioral issues. They can, just like people without Down syndrome, they can run a range of happy, cheerful, um, placid, withdrawn, sullen, obstinate, defiant, oppositional, rigid. So those are characteristics that you would use to describe just about anyone. They do have some visual impairments. About 60% of people with Down syndrome have ophthalmic disorder. They're nearsighted, maybe farsighted, astigmatisms, some strabismus, so that kind of wandering eye, nystagmus, so the eye that goes back and forth. Sometimes they have cataracts, they may have droopy eyelids. About two-thirds of people with Down syndrome have hearing loss. Um, so part of they're predisposed to recurrent ear infections. Sometimes they develop sleep apnea as a consequence of the upper airway obstruction from the enlarged adenoids and tonsils. Remember the thing with the eustachian tubes. So eustachian tubes they don't develop typically in people with Down syndrome. They're often more narrow. They don't work as efficiently. Sometimes, they're not, as the person grows, they don't have that angle for drainage. It's difficult for them to drain. So you often see people with Down syndrome that are just full of this just gunk. And if anybody has worked with people with Down syndrome, you'd probably agree with me. They also often have orthopedic problems. They have loose ligaments. They have atlantoaxial subluxation, which we'll talk about in a little bit. They're prone to hip dislocation. They have some patellar instability, flat feet. So, orthopedically, they have some challenges that they experience throughout their life. They're not um, terribly agile, or physical activity can be a little bit of a challenge for them. People with Down syndrome also tend to have dental problems, high prevalence of periodontal disease. They have missing teeth, they have smaller teeth, sometimes they're fused together. As I said, their teeth tend to erupt a little bit later than typical. They're prone to congenital heart disease, which can lead to congestive heart failure. And in people with Down syndrome, the progression is more rapid than it would be in with people without Down syndrome. And really, really high prevalence of respiratory conditions. They're about 60 times, have a 62% or 62 times higher chance of getting pneumonia and respiratory conditions. And this is a major cause of death for people with Down syndrome. So they also experience often GI malformations. They have issues with feeding sometimes. They may have vomiting or get aspiration pneumonia, sometimes stomach blockages. This isn't a really high prevalence of these issues, but they can be present. They do also have endocrine abnormalities. The thyroid regulates metabolism, so diabetes tends to be much more prevalent in people with Down syndrome. They tend to be also, they're shorter in stature, but they're also are a little bit, can be on the heavier side as well. They have a lot of skin conditions which can affect their quality of life. They have things like a dermatitis. They have alopecia, so they sometimes lose hair. They have some flaky skin, inflamed lips, etc. So some of those things can impact their quality of life. So medically and therapeutically, you'd want to make sure that they are following up with their healthcare providers with regard to any heart disease, any respiratory issues, vision, hearing, thyroid, all of those things. You want to make sure that they are getting regular and routine medical care. They should also be seeing dentists routinely. Really prevalent dental issues, so it's important that they follow up with their dentist. They should also be referred for early intervention services. Down syndrome is one of those diagnoses that is evident at birth, and all of the research shows that the earlier they are able to get services and get support, the better the outcome. So with people with Down syndrome, and it's evident at birth, they should be getting birth to 3 services immediately. Also, once they transition to schools, they should be getting services within the schools, and then they should be getting services as they transition out of the schools and into whatever setting that they may ultimately be in. Also, supportive employment is important for people with Down syndrome. So there can be different types of supportive employment, whether it is job coaching. Some of you may be familiar with that, where a person is either assigned to a setting with multiple people with disabilities, and they teach them the skills, and then they're just there on site to make sure that everything goes okay. And in those cases, it may be that they're on site full-time, or it might be that they go on site on routine scheduled visits. There's also sheltered workshops for people who have less function. And in those cases, those situations, they are very menial tasks that are repetitive. They're rote tasks so that they can learn how to do it and be consistent. So if you've ever seen people who do things like roll up the silverware for restaurants, or stuff binders, not binders, but flyers or folders for conferences and things, those are often done in a sheltered workshop with people with intellectual impairments. So also, just general employment skills are important. Adapting the task so that they can participate, whether it is in a leisure or sports activity, whether it's in a life skills, whatever it is. People with Down syndrome, like people with intellectual impairment, they like reinforcements. You want to make sure that the reinforcement is meaningful to the person. I prefer to not use food. A lot of people use food as a reinforcement. That sets up a lot of issues with eating disorders. It's better to find something tangible but not food that can serve as a reinforcement. And make sure that it's meaningful to the person. So one person might like to have stickers, or might like to get 5 minutes of computer time as a reward, whereas that might be meaningless to another person. And if it's meaningless to another person, it doesn't serve the function of being a reinforcement. Visual and tactile cues are important. Remember, auditory processing is an area of challenge for people with Down syndrome. So providing them with that visual, like we talked about with intellectual impairment, and having that visual schedule so that they can learn to wash their hands in different environments. Modeling is also important. They learn through observation. So modeling in the sense that you might show them how to do the task and then have them do it. Reward systems we've talked about. Positioning is important. You want to keep them moving for as long as you can, and prevent any issues that might develop later in life. Remember, they have low tone, they have flat feet, prone to hip subluxation. So you want to be mindful of the position and not put extra stress on those joints or those areas. Helping them develop their motor skills, particularly fine motor is more of a challenge for people with Down syndrome. The structural issues with their hand can cause some challenges, and help them engage in self-care. There's no cure for Down syndrome. It is what it is. Life expectancy has gotten much better than it used to be. In 1929, life expectancy was 9, and now it's 50 plus, and it's not unusual for someone with Down syndrome to live well into their 50s and beyond. They're most likely to die from respiratory disease. In adolescence, there is this little bit of a deterioration that they're not 100% sure why it happens, but you can see a decline in function in adolescents with Down syndrome. It's often attributed to maybe it's hypothyroidism, is it depression? They don't really know what happens. It is likely linked to puberty and hormones in some way, but not a definitive link. But there you can see a decline that lasts for a year or more, and then they go back to their prior level of function. Later in life, around in their 40s and 50s, you see a mental deterioration. Just about all people with Down syndrome by the age of 50 have the pathological plaques and tangles in the brain that are hallmarks of Alzheimer's disease. They don't necessarily have full-blown Alzheimer's disease at that point, but there is evidence of the plaques and tangles. And finally, I just want to talk a little bit about atlantoaxial subluxation because it is present in 75% of people with Down syndrome. And it's a term used to describe the laxity of the ligaments and the muscles that surround the first and second cervical vertebrae in the axis. This can lead to irreversible central nervous system damage. So it's recommended that they have x-rays when they become mobile and regular medical care if it's present, but if they're asymptomatic. So activities that cause stress at the joint will need to be approved by a physician. And there's some disagreement with doctors about should they participate in rough and tumble activities or not. But atlantoaxial instability is characterized by excessive movement at the junction of the atlas and axis, so C1 and C2. Atlantoaxial instability is caused by this ligamentous or bony abnormality, which can lead to neurological symptoms. It may present with no symptoms at all, and some patients experience things like pain, and they describe it like a vague neck pain or a headache. But because the vascular supply and the spinal cord are nearby, vascular occlusion or myelopathy could also occur. So they can also experience some neurological symptoms. They can have a lack of coordination, they can have an abnormal gait, clumsiness, trouble walking, sometimes limited mobility, torticollis, which is also called wry neck, where there might be some almost contracture to one side or the other, easily fatigued. It's possible that paraplegia or hemiplegia or quadriplegia could occur as a result of the atlantoaxial instability or subluxation. So just in general, if they are at risk, they should be seen by a healthcare professional and be evaluated through x-rays and whatever other intervention is appropriate. If they have it, it can progress and it can ultimately lead to spinal cord compression. So it's important to just be aware of this, particularly if you are working with people with Down syndrome in any type of a physical capacity. All right, that's it for Down syndrome. Have a good day.